Hello, my name is Jaspreet and I'm a second year's master's student. In today's class, we will discuss simple dressing change. This is a skill I hope you will be able to practice during your clinical shifts and master at the end of the semester. The learning outcomes of today's class will be exploring the concept of asepsis via dressing change and care of a surgical wound. We will review the principles of aseptic techniques and how to maintain a sterile field. You probably have touched basis of aseptic techniques in a Nurse 224 class. We will analyze different types of wounds and the phases of the healing. We'll review the types of a drainage, and finally, we will be identifying various drains and tubes used in wound management and the healing of the incision. First, we'll talk about the types of wound healing. In other words, phases of the wound healing. The wound healing is a process that repairs the skin damage. It goes through various stages of the healing based on the severity and the type of the wound. Understanding these stages of healing can make us understand how we're going to care for the wound. There are three types of wound healing: primary, secondary, and tertiary. You probably remember these from your Nurse 224, but they're here again. Primary wound healing refers to when the wound is closed using sutures, staples, or any adhesive strips. The wound closing process produces tissue loss and lets the body focus on healing smaller areas than the large gaping or open wounds. Secondary healing is when wound cannot be closed due to excessive tissue loss and is left open to naturally heal by the body mechanism. This is common in wounds with uneven edges, surfaces, or where the body movements make wound closure impossible. This process of healing takes longer than normal and increases the risk of infection. Whereas in a tertiary healing, the primary wound closure is delayed due to the presence of infection in the wound, as the early wound closure may trap or worsen the infection. In these cases, the wound is allowed to drain and closure is awaited until adjunct therapies like antibiotics start to work and the infection is clear. Next is the stages of the wound healing. Different types of wounds go through different stages of healing, starting from the initial reaction of the body to the formation of the new skin. The wound healing occurs in the four stages. First one is the hemostasis. In this phase, the body's initial reaction to the injury is wound causes the blood and other fluids to leave the body. In the initial response, the blood vessels constrict to reduce the blood flow out of the wound and then allow platelets and thrombocytes to clump near the wound to form a fibrin network. This fibrin network acts as a barrier against potential infection. Next is the inflammatory phase. After the hemostasis is achieved, the healing process begins. The immune cells and the white cells rush to the damaged tissue and start causing inflammation. It cleans the wound and removes any waste present. The excess accumulation of these cells can cause inflammation around the wound. This process continues within the first 3 days of the wound healing. Next is the proliferation phase. In this phase, the body focuses on wound closure by repairing damaged blood vessels and forming new tissue. This tissue formation further occurs in 4 steps. First is the formation of a new skin tissue, which may include epidermis, dermis, or hypodermis layer. Based on the type of wound, it is called epithelialization. Next is the angiogenesis, which is the formation or repairing of the new blood vessels. Then last is the collagen strengthening and contraction, where reduction and closure of the wound occurs. This process starts around the 4th day of the healing process, and the combined blood vessel repair and a tissue regeneration process is called granulation of the tissue. Remodeling or maturation phase. This process occurs approximately 2 to 3 weeks after the initial injury and may last up to the 1 year. Here, the internal wound is usually healed and the body replaces a temporary granular tissue with scar tissue, which is strengthened by the concentration of a collagen over the time. Next is we're going to review the principles of the asepsis. As you remember from Nurse 224, asepsis is the absence of a pathogenic microorganism, which can cause disease in the host. Let's review the fundamental principles. The more you talk about them, the easier it's going to be for you to remember when you're in a clinical practice. The first and foremost principle is protecting the key sites, like wounds, and the key equipments, for example, dressings, by keeping them free from the microorganisms. Next, all organisms on the sterile field must be sterile. You cannot place unsterile gauze or equipment in your sterile field. The sterile object remains sterile only when touched by another sterile object, means you cannot touch your sterile area with a bare hand or with unsterile gloves. A sterile field or object out of the vision is considered contaminated. So the area below your waist and your back is considered contaminated. While performing the procedure, it is important that you do not turn back to your sterile field. Next is a prolonged exposure to air and contact with a wet object can contaminate the sterile field using capillary action. So avoid spilling any fluids over your sterile area. Any puncture or a tear through the sterile area can break the sterile barrier as well. Next is the fluid flows in the direction of the gravity. So it is important for you to clean the incision from the top to bottom, because if you clean from bottom to the top, the fluid might come back to the bottom of the wound due to the gravity, which does not serve any purpose. If in doubt, consider it unsterile. For example, if you're not sure that your gauze or a forceps touched any unsterile object, then it is safe to discard rather than using an unsterile object. Last is the outer 1 inch of your sterile field is considered contaminated. So anything you touch, anything that touches the anything that touches the outer edge is considered contaminated as well. Next is the scenario activity. I have posted 2 questions for a little brainstorming. Just think about, as a student, you're working in a clinical area and you're performing a urinary catheterization using aseptic technique, and your patient accidentally touched the tip of your catheter. What should be your next step? And also try to think about the 5 nursing procedures where you will be using an aseptic technique. Next, we will talk about the nursing responsibilities with a simple dressing change. Before performing any skill, it is important to know if it is within your scope of practice or not. Many wound care procedures are considered entry to practice competencies and may be performed without additional orders. However, when you do a dressing change for the first time in the clinical practice, make sure your clinical instructor is there to help you and give you feedback on your skills so that you can improve as you progress. Before starting the dressing change, make sure there is an order for it and check that. As a registered nurse, you do not necessarily need an order for simple dressing change. However, as a student, always check, because sometimes there are specific orders, like an orthosurgeon might specifically order some dressing should not be removed or changed for certain days. So yeah, always check. The next step is the assessment. You would assess the patient's comfort and a pain level and offer them some pain relief before performing the dressing change, especially if you anticipate the procedure may cause a pain. Then you would perform the dressing change, as this is your responsibility as an RN. You also responsible for care of the tubes or drainage coming from the incision. Some wounds will have a different surgical drains to drain an abscess or a wound or a surgical wounds. And assessing the wound drainage is very important because you can identify the early signs of infection from the color or the smell of the drainage. Next is, it is important to know why we need a dressing change. There are few reasons. First is protection. As a nurse, it is our responsibility to regularly change the dressing so we can prevent the infection or any other complications. During the dressing change, we will clean the wound and assess the progress, healing, or worsening of the wound. The second is a healing. Not all wounds need dressing, but covering the wound with appropriate dressing promotes a healing process. For example, removing excess moisture from the wound bed promotes granulation of the tissue. Another thing is minimize the scarring by supporting the patient and supporting the early management. Keeping the wound soft through the healing process helps to minimize the scar. The application of a physician-recommended ointment during the early stages of healing can keep skin soft and pliable around the wound. It is important to understand that healing is a complex process, and any interruption in a healing can lead to non-healing or a chronic wound. In slide 7, we briefly discussed the nursing responsibility in addressing change. So in this section, we will discuss each nursing responsibility in a detail. First is the wound assessment. Assessing the wound is one of the key nursing responsibilities, which does not require any order. In wound assessment, first you need to assess the appearance of the wound. How does it look? Is it red, uniformly pink, yellow, black, or light pink? Because identifying the tissue color allows for the appropriate selection of the dressing needed to help with the healing. For example, if the wound appears red to pink, the goal should be to keep the wound clean and moist, as the pink wound is an indication of a granulating tissue. But if the wound bed is yellow, the goal should be managing slough or exudate, as the yellow slough can impede the healing process. Along with the wound color, you will also need to assess the surrounding skin area. The 2 to 3 centimeter area beyond the wound edges is called the peri-wound area, which need to be assessed. You need to see if the surrounding skin is dry, intact, erythematous, or macerated. Assessment of this area is important as the risk of a breakdown under the dressing is more common as compared to the other skin in the body. Next is the thickness of the wound. This assessment includes the identification of exposed layer. For example, the loss of epidermis is categorized under the superficial wounds, whereas if the dermis is involved, then it is called a partial thickness wound. And at last, the exposure of a subcutaneous fat, muscle, or bone is categorized under a full thickness wounds. Next is the wound size. Measuring the size or dimensions of the wound is an integral part of wound assessment, as the serial measurement of the wound length, width, or depth can provide a trend indicating the presence or the absence of a healing process in the wound. Next is the wound healing, wound closure. Wound healing by primary intention usually requires well-approximate edges. The wounds can be closed with metal clips called staples, sutures. It could be soluble or insoluble stitches, adhesive strips, we call it steri strips, or a topical glue, which in other words can be called as a surgical glue. Tissue flaps and skin grafts are the 2 other surgical wound closure methods, but that we will discuss under the complex dressing change. It is remembered to assess and document if staples, sutures, or steri-strips are present, intact, or they're not intact. Next, we will discuss the wound drainage. Drainage or exudate is produced by different wounds as part of the natural healing process. It usually maintains the moist environment in the wound. So it is important to assess the color and the amount of the drainage to identify the progress or any changes in the wound healing. The drainage can be bright red, which is the first one. It's called sanguinous. Second is serosang, which is light pink or red. Third is a purulent, which is cloudy or a milky. And the last one is a serous, which is a clear. Next is the amount of the drainage. If you don't see anything on your dressing, it's considered wound as dry wound and there's no drainage. Second is a scant. If the wound is moist but the drainage is not measurable, then it is called a scant drainage. The third is a small. As you see in this picture, there's a small area. So if the area is less than 25% of the dressing, it is considered small. But if it covers more than 25% but less than 75%, it is considered moderate. Whereas more than 75% of dressing, soiled dressing is called large amount. And if you see the drainage is coming out of the wound, you can see out of the dressing, it's completely saturated, or drainage is swelling the patient's clothes, it is called copious. Next, how do you know what to bring to your patient's room? It is very important, as you do not want to waste supplies. Prior to dressing change, you can look at the physician's order, which will indicate what you need to use for the wound bed and the frequency of a dressing change. Secondly, you can read the previous wound care documentation to know what you need to bring. If you can't find anything, you can talk to your buddy nurse. Or the other things, the basic things you would need for the dressing change include non-sterile and sterile gloves, dressing tray, normal saline, sterile gauze, measuring tape, scissors, and an adhesive tape. The frequency of a dressing change depends on the physician's orders, or you can change if the dressing falls, or if you see the drainage is not contained, your dressing is getting soiled, you can change the dressing. Next is the dressing change. During the dressing change, it is important to follow the aseptic technique throughout the procedure and perform hand hygiene at 4 points of a patient contact. It will prevent the transformation of the infection. Besides this, we have already discussed, you will need to assess the patient and administer analgesic 30 minutes prior to dressing change. Adjust the patient's position to ensure a patient is comfortable prior to and during the procedure. This is an example of a patient-centered care. Setting up the environment is also important. Provide privacy and a plan in advance, like where you're going to set up your sterile field. And is the area clean and dry? And is it at your waist level? We usually use the bedside tables to set our sterile field. Now, what we're going to do first is we're going to explain the procedure to the patient and perform a hand hygiene. Then open the outside sterile package and discard. Grab the outer surface and the outermost tip. Open the flap away from you as you see in the figure B. Next, now grab the side flaps and open towards the sides, one by one, and let it lie on the plate as you see in figure C and figure D. In the end, grabbing the outermost corner, pull the last flap towards you and lay on the border. Make sure you do not touch or reach over the sterile field and touch only the 1 inch of the sterile field. As you can see in a field E, that person is touching only the outer edge of the sterile field. Add necessary sterile supplies and pour the cleaning solution without touching the sterile tray. The cleaning solution container must be used only by one client, and container must be labeled with the patient's name, date, and a time. Once container is opened and it is over 24 hours, you should discard the container. Now don the sterile, non-sterile gloves and then remove the old dressing and assess the wound. Discard the non-sterile gloves and dressing appropriately and perform hand hygiene. Put on the sterile gloves or the non-sterile gloves if using forceps. Clean the wound with 2x2 gauze soaked in a cleaning solution as shown in a picture. You will start with the center and from top to bottom, from proximal to distal with one stroke. You cannot go up and down. After that, then clean the 2 to 3 centimeter area around the wound, which is called a peri-area wound, in the same fashion, from a top to bottom, using one glove at a time. One gauze at a time. You will dry the gauze in the same fashion only if needed. Apply gauze to the wound and skewer it with the adhesive tape. Label the date and time of the dressing and document the procedure in a wound care assessment sheet. There are 3 types of adhesive tapes you may see in a clinicals to secure the dressing. The first one you could see here is a Me-Pore. It is like a Band-Aid, but with a gauze in the center. And the second one is the Montgomery ties. It is used to secure a large dressings. And the third one is a paper tape. You guys probably have seen it already. Next is the types of the wound drain. Drain systems are used to remove drainage from wounds, which prevents infection and delayed wound healing. Here we will talk about the 3 main types of surgical drains based on the open and the closed system. First one is the Penrose drain. And it is based on the open system. It deposits the drain on a sterile dressing, and the dressing is checked periodically to ensure the drain is functioning and the drainage assessment is completed. The second and third drain are the part of the closed collection system, and it is a sterile. The second drain is called Jackson-Pratt or the JP drain and can hold up to 60 to 100 ml of a drainage. And the third drain is called the Hemovac drain and can hold up to the 500 ml of a drainage. Drains are usually sutured to the skin to prevent the accidental removal. The drainage site is covered with a sterile gauze and checked periodically to ensure the drain is functioning and not leaking. Next is assessment and care of the drain. It is important to always get in the habit of regularly assessing the skin at the insertion site. The sign of the infection may include increased redness, warmth, swelling, or tenderness around the insertion site. Secondly, you will assess the amount and the appearance of the drainage and whether the drain is secured, whether the suture is intact or not. Next, cleaning the drain insertion site. The supplies are almost same, except you will use a drain gauze to dress the site. The drain gauze this is a drain gauze, and it has a slit in the middle that you will put over the insertion site. The cleaning technique of the drain is also different than simple incision. In a simple incision, you went from top to bottom, but here you will clean in circular motion, starting from the center, going to the outwards. So you will use you will clean 2 to 3 centimeter of the area around the drain. Next is, and then you will cover the drain with the gauze and secure it with the tape. Next is the tube care and the removal of the drain. I have posted videos, links that you can see how to do a tube care, because the nursing care of the drain includes emptying, milking, keeping it secure, and assessing it regularly. That you will be able to watch this in a almost 3 minutes of video. And then removal of a drain is within the scope of a practice, but you have to check the physician's order, and you can remove this under the supervision. So you have to double check what you can do before doing it for your and a patient's safety. Next is the wound closure methods. These you can see few commonly used in closure methods. First is the staples. These are the small metal clips used to close approximated edged wounds. Staples are removed by using a small device called a staple remover. This is a staple remover, as you can see. The sutures can be, next is the sutures. The sutures can be removed using a suture kit, which will contain sutures, either thumb forceps and a gauze. Third method is a Steri-Strip. There are few types of adhesive tape used either in a small incisions like scope sites or after removal of the staples or the sutures. Next is the removal of the sutures. So there are some videos related to dressing change skills, including removing staples and the sutures. The videos can be located under the lab learning resource on your Nurse 225E class site. Please watch those before your lab practice. So this is the end of my presentation. I have attached the knowledge application worksheet for you guys. Please try to complete the scenarios, as you might encounter similar scenarios in your clinical practice. Also, do not forget to complete the weekly knowledge checks before your lab practice. Thank you and have a nice week, and good luck with the dressing change in your clinical practice. Bye-bye.